morning, and my appreciation especially to the IT team and the support officers. Thank you very much. So friends, you may have heard recently that government's rules and regulations around holding meetings like ours have changed. And the new rules and regulations makes the face-to-face meeting possible. And going forward, that is what the government expects us to do. However, this morning we are meeting virtually, and as such, this meeting will be deemed informal. So the business of this meeting that is going to be transacted will formally be ratified when we hope to meet face-to-face in September. So without further ado, again, very welcome to all of you. Really grateful to you for making the time to be with us this morning. And I'm now going to ask Michael Carr from the London Borough Brent to take a chair for a moment while we transact the formal part of the business, namely the election of chair and the vice chair. So, Michael, over to you.
Yes, good morning. Please may I invite nominations for the positions of Chair and Vice Chair of the North West London Joint Health Overview and Scrutiny Committee.
I would like to nominate Councillor Ketan Sheth, please. Can I have a seconder?
Councillor Saunders, I second the nomination of Councillor Sheth.
Thank you.
That's agreed. Are there nominations for the Vice Chair position?
Can I nominate Vice Chair as well?
Yes.
Councillor Daniel Crawford, please. Nominate a name as a Vice Chair. Can I have a seconder, please? Same, Monica. Thank you, Monica.
Councillor Saunders, and I second that nomination. Thank you.
I take that as agreed as well. Thank you.
Thank you very much, Michael, for doing that part of our business for us. And thank you very much to Rekha and Monica and indeed the entire committee for your nominations. And I really do appreciate your faith in myself and Dan, and we look forward to serving the committee to the best of our abilities. Thank you very much. So the next part of the agenda item is apologies. Michael, have you received any apologies this morning, please?
We have apologies from Councillor Ian Bott from the City of Westminster.
Thank you for that. Any other apologies?
Chair, we have apologies from Councillor Al-Nagi as well.
Thank you for that, Daniel. Grateful to you. So the next item is a declaration. And as far as declaration is concerned, let me be the first one to declare that I am the lead governor of Central and Northwest London NHS Foundation Trust. Friends, are there any other declarations? Thank you. So we move now to the minutes. We will take the minutes as tabled, and as I've said a few moments ago, we will formally ratify those minutes that dates back to March of this year at our September meeting. But just as far as matters arising is concerned, as far as action points, I don't know about you, colleagues, but I was able to pick up 3 points, and perhaps we can ask our NHS friends to update us on that. So the first action point that I see is Stephen Bloomer was to provide us with a breakdown of costs and spending to the committee. The second action point was Leslie Wards was to provide further information on work and spending surrounding the IT and such matters. And Rory Hegarty was to provide us with the information around involvement charter with the committee once available. So as far as action point goes, those were the 3 that I was able to pick up. I don't know if there are any others, but let's just find out where those action points have reached in the system. Anybody able to assist me? Nicola, I don't know whether you have the information on that, and perhaps I can ask our NHS colleagues where we are on those 3 action points.
I don't have the information. It hasn't come to me, I'm afraid.
Okay, so can I ask our NHS friends to tell us where we are on those 3 action points? I saw Rory on my screen a moment ago. I'm not sure whether
I'm here.
Leslie and Joe are on my screen. I can't see them at the moment. Leslie, Joe.
Anyway. So I thought those actions had been completed, so let me check. It may be sitting in an outbox somewhere. We will send something over this week. Sorry if those things haven't come through to you.
Okay.
I certainly thought I'd shared the involvement charter personally, but if I haven't, I will resend that. Okay,
so if you could share those 3 pieces of information, it would be really helpful. Thank you very much indeed.
It's Leslie. I'm so sorry that you can't see me, but I'm
here
now.
I can now. Welcome to both you.
I've seen all 3 pieces of those, so I will, with Rory, we'll make sure that actually we thought they had been sent. If they haven't, we'll make sure that those are out to you.
Thank you very much, and very welcome to you both, ladies. I can certainly see you on my screen now. Thank you. So, once I have received that, colleagues, I will be very happy to share that with the rest of the committee in due course. Thank you very much. So, friends, we come to the first substantive item, which is the development of the Northwest London ICS. We've just heard from Leslie. I'm not sure, Leslie, whether you're leading on this or whether Joe is. I can see you nodding your head in affirmative. So if you could please introduce this paper and perhaps other colleagues who are on the Zoom call, on the Teams call, who might want to contribute to this paper as well. Thank you and welcome.
So thank you very much, everybody. It's probably, I'm just going to move my mask because some of you know me and some of you don't, but that's what I look like. So I'm Leslie Watts. I'm the Chief Exec at JHOSC, and I'm also the interim CEO for our integrated care system, and have been probably for the last couple of years working together with Joe as the accountable officer for our CCGs. So thank you for inviting me to talk to you about where we are with our ICS. And for those of you just to say to you that we do brief council leaders once a month, but for those of you who haven't heard this, Ketan, if I'm not providing what you want, you just need to shout out, all of you, about the particular areas that you want to hear about. But our integrated care system is reasonably well developed now, and we have just actually submitted our development plan to NHS England. Our integrated care system brings together our health and care local authority colleagues, and actually Northwest London is probably, so I've been told, the biggest integrated care system in the country. So it's pretty big and it's pretty complex. It brings together care for about 2.4 million people. We have 4 acute trusts, 4 community mental health trusts, 45 primary care networks, 8 boroughs, 2 specialist trusts, all working together and trying to work together to make sure that end-to-end pathway for patients is joined up in a way that we haven't quite managed previously. But what's happened during the pandemic has meant that actually, if there is a silver lining in this awful pandemic, has been that we've learned to work together and to accelerate the things that we've wanted to do together for some time. Our vision is to improve life expectancy, the quality of life for everybody, absolutely to reduce inequalities. We know that if we didn't know it before, we absolutely have had a mirror put in front of us that says you are not treating people equally, both in terms of access to care and indeed those outcomes from care. And it's something that we're pretty determined to do something about. Overall, our health outcomes in Northwest London are pretty good, but we need to do better. And we believe we can do that. We also have academic partners. So we have so with Imperial College, Brunel, and other higher education institutions, we have some of the best education in the country as well. So in terms of our priorities right here and now, and I'll talk about those first, and then I'll try and talk about them in the strategic context. So right here and now, our biggest priorities are to restore the elective work programme. You will know that during the last year, our ability to treat patients on our normal waiting list has been severely restricted, and so we have a big programme of mutual support throughout Northwest London to ensure we recover that elective programme as quickly as we possibly can. And we do that, again, in the context of ensuring equality of access and outcomes. So people shouldn't be being treated more quickly in one part of our sector than they are in another part of the sector. And we're trying to ensure that we work together to do that. We are also, as you know, have been together with you, with our local authorities, and Pippa sitting beside me, and we'll talk in more detail about this later, but we've absolutely been focused on the vaccination programme. We want to make London and Northwest London as safe as possible for all of our citizens, and we've been working, and our staff together have been working to ensure that we give ourselves the best possible chance to do that. We are experiencing pretty high levels of the emergency work at the moment, so actually we're dealing with that and trying to make sure that doesn't impact the work of elective recovery. We're doing a lot of work, actually, again, with our local authority colleagues about the health and well-being of staff. That's one of the things that we're focusing on. And we are, of course, planning, and in fact, we're probably entering the third peak of COVID as we speak together now. So we're planning together from primary, secondary, tertiary care about how we deal with the third peak and how we ensure, again, that as far as humanly possible, we don't allow that third peak to impact the elective workload. I think in the briefing, which I think you've had, Ketan, we've outlined the more strategic pieces of work. And I'll just talk a little bit about some of the governance arrangements. So we together have set up our partnership board and our health board. We've also focused integrated care partnerships in each of our boroughs, which bring together primary care, community, mental health, and indeed our local authority, particularly our social service colleagues. So again, that we can actually make real our promise to our population of making care as close to them as we possibly can, where that's possible, but ensuring that we provide the best possible secondary care services. One of the things that I do want to talk a little bit about is what that means. So when because some of this stuff will be tricky, and some of it will not be without controversy. So if we are determined together to ensure equality of access and outcomes for health for their patients, but for our citizens and our population, that may well mean that we will need to move resources, be that between secondary care and the community and primary care, or be that between boroughs. And that's something, as time goes on, that we will need to more forensically and in a more focused way have a look at what that might mean. The other thing it might mean, if we think of the strategic context of ensuring on a sustainable basis that we provide world-class care, and actually we deal with the backlog of patients that we've got, that might mean that actually we have to look after patients in a different way, which, for example, the high volume, low complexity cases that we've been dealing with, we've actually centred those in particular hospitals for two reasons. One is we can make most productive use of our resources by concentrating specialties together across the sector. And the second thing is we can protect those elective cases because they are not impacted by the emergency workload, which may be COVID positive. So all of those things are being discussed quite openly and transparently with your officers. And all of those things are things that I hope that you are well aware of and that we've been discussing together to ensure that as many patients as possible are treated. Before I go on, Ketan, I think it might be worth getting Pippa to talk in a bit of detail around the vaccination programme, if that's all right, and then I'll go back to some of the more strategic things that will be coming up in front of us in the near future.
So Leslie, you know, we've got item number 6 on the agenda, where we got COVID-19 vaccination update. Do you think it'd be right to take it at that stage, or do you want us to hear from Pippa now?
My apologies. I'll leave it for that. The other area I just want to spend just a minute on, and then potentially take any questions if you like, Ketan, is the other. So I've talked about the emergency workload in general. I've talked about the elective work. The other area where we have increasing concerns, as you know, and increasing growth in demand has been around mental health. And particularly, and again, you're going to be talking about this in a minute, around some of our concerns around our children and our young people. But again, when I'm trying to build the whole picture, all of those things come into play in the discussions that we will have in the near future and into the medium term about how we will need to organise ourselves and how we need to think about the allocation of our resources. But what I do want to reassure you is that actually the health services across North West London, I think all chief execs would say, have never been more committed to working together. So that era of competition has gone, the era of collaboration is not only here, but is welcomed by us. And we have seen relationships both within health, so within all of the organisations that I've described, but between health and our local authority colleagues, we've seen those actually mature and become pretty bonding in a way that makes all of us feel that we're committed to the same thing. That would be the feedback from our health chief executives. There will always be tensions, actually, and rightly so. We need to have some open discussion and debate about this. But actually, people are trying very hard to ensure that those are open and transparent discussions and that have citizens and patients right at the centre in a way that we've always wanted to, but we've never quite got to. And I'm going to finish by saying I want to pay tribute to all of our staff. Actually, they've been pretty amazing. Our primary care colleagues, I can see Mahini on here at the moment, have continued both with primary care services, but actually have been at the forefront of the vaccination, of the giving of the vaccinations, and again are committed together with us to dealing with some of the long-term issues that we've got. But we are in this together, we feel together about it. And I'm going to stop there.
Thank you very much, Leslie. Really, I'm grateful to you. And can I just echo, on behalf of my committee, our thanks and appreciation. And indeed, we really do mean this most sincerely, that all the frontline NHS staff have been absolutely amazing, and heartfelt thanks to each and every single one of them goes from this committee to them. So do pass on our appreciations to them. Thank you very much for that presentation, and obviously there are a number of themes that comes out of the written paper as well as the presentation now, and you touched upon halfway through about the governance, and then you went on to talk about the quality of service and the outcomes, and you talked about partnership, and you talked about the staff. So all of those themes are going to be picked up by my colleagues in form of questions, unsurprisingly. So let me start with the first theme and first question first, and Leslie, if I may. So you talked about how big, how complex this new ICS structure is, and you talked about it being potentially the largest, the biggest in the country. So at the moment, I just wanted to find out how effective it has been thus far in its journey, bearing in mind that it is a voluntary arrangement with no legal underpinning thus far.
So I will give you my view. I mean, others may have a different view. I would say it's been pretty impressively productive. So during COVID, you will know that North West London was one of the hardest hit areas, both in London, but actually nationally, and was hit pretty early. We would not have coped with the numbers of patients who were very, very unwell and needed intensive care if we had not worked together. So both by doubling and in some cases tripling the amount of ITU beds we had in particular hospitals, but actually by sharing resources, so staff and kit, and indeed actually transferring patients between each other. That I think has been recognised by London as being an amazing effort. Again, we would not have been able in the second peak to continue with, so we continue to treat all of our cancer patients and indeed to do some of our elective program. We would not have been able to do that without separating in different hospitals, as I said to you earlier, the high volume, low complexity work, but still continue to see very large numbers of COVID patients. If you'd come into our hospitals during this period of time, you would not have recognised them. They looked very, very different. And we learned from each other, actually, how to cohort patients, how to organise wards, the different infection control procedures. We absolutely learned from each other and were informed by, as well, the predictions coming out of our academics, out of Imperial, out of the way that we used our WISIC, so our whole system integrated care data, actually, which is well developed in Northwest London. Again, London are looking at that. So that way of working, sharing data, sharing staff, sharing all of our resources, learning from each other, actually relying on each other. So our community and mental health colleagues, the way they looked after patients in their own homes, in nursing residential homes, and took patients much more quickly out of hospital. Again, that mutual aid allowed us to keep going during very, very difficult times. So I would say that, and certainly you will know that we had some very challenging times during all of this. There were periods during the first peak where none of us knew what was coming, actually, and weren't sure what we were planning for. But people kept going by working together during that. So that's a long answer, but I would say impressively.
Thank you very much. So I'm now going to bring my colleagues in. And before I do, just a very quick reminder that if we can please keep our questions and equally our replies as brief as possible, because I know there is going to be a lot of interest from our colleagues, and I want to be able to get as many questions as I possibly can. And in my task, if I can enlist assistance from Dan, if you could just remind me if I miss out anybody who's raising their hand. And Michael, if I can enlist your assistance as well, if you could please keep note of any key headlines, and it would be helpful if I can bring you in towards the end to remind us of the top headlines for us, please. So Lucy, can I bring you in at this stage, please? Thank you.
Thank you. Yes, I welcome what Pippa says about partnership working. That's all very encouraging. I just wanted to ask a question to try and understand this. What about the membership of the Ics Board? At the moment, at this point, I understand the members are the CE of the London Borough of Harrow and the DPH from Brent. With all due respect, there are significant differences in the needs of inner and outer London populations, health populations. So I think from point of view of Hammersmith and Fulham that we need certainly a Hammersmith and Fulham representative or an inner or KNC or Westminster on the ICS board.
So thank
you.
So very quickly, I guess there's two things. One is a balance between how you make a board workable and how you are absolutely inclusive. And just to bear in mind, two things that we also have, which is we have a monthly briefing with all leaders of all local authorities. We have nearly a weekly meeting, actually, with a chief exec representative, so Stuart, Carolyn Downs, and Sean, and we have a monthly meeting with the chief execs of all local authorities. And on top of that, we have the Senate, which will be in statute, which will have everybody on it. So that's an engagement meeting which will have all parties in the integrated care system on it. I will send out, if you haven't had it, I will send out the development plan that describes all the suggested governance arrangements and puts in all of those different groupings, if that's helpful.
Thank you. Lucy?
My understanding when this was formed was that the representation on the ICS board was going to be on a rolling basis, so it wouldn't, it would be exchanged, there'd be different councils represented on the board.
So I'm happy. So I'm happy to discuss that with. So to some extent, that's a local authority discussion about that representation, Lucy. But I will take that away, and I will speak to Penny about having that discussions with all the leaders about whether the preference is for a roving representation.
Thank you.
Thank you.
And could I just ask one follow-up? Why aren't the ICP Borough Leeds members of the ICS board?
Because, well, actually, again, it comes down to there are 8. So
yeah.
it comes down to how, and if you consider that actually those staff in general will all report to chief execs in the sector. So I think that was the other reason. But again, this is an iterative process. We're learning actually across from all ICSs in the country. And there is an ICS national board that is looking at all of these things. So I think some of this stuff is still to be ironed out, if I'm honest with you.
And how is, thank you very much. Can I just ask one more question? I've had a look at the structure and it's quite complicated in terms of the ICS, but I understand the ICS board is the centre in terms of that's the decision-making board, and that's the one who makes the decisions about the funding. You said that they feed through these decisions, but I've had feedback from our council that the ICS board communication and information is limited and difficult to interpret.
Well, so thank you for that. Thank you for that bit of feedback.
Sorry, I didn't probably couch it.
No, it's fine. It's fine. So this is, I mean, frankly, it's complicated stuff, actually. So just if I go quickly back to the three raison d'etres of the ICS, which is the strategic planning, and you're right, there will be a unified budget, a health budget that comes through the ICS. Actually ensuring the delivery of the care that we've all agreed, so via actually the provider units in the way that we've described, or indeed through the integrated care partnerships. And then the third thing is oversight and assurance. So I think other than that, we would be very keen to see as much decision making taking place either in the provider, so they will be responsible for the care they provide and for the decisions they take, and indeed the integrated care partnerships in each of the boroughs. Our staff, we put pretty senior people in all of our boroughs to ensure that actually decision making and the allocation of the resource once it's down in the borough those decisions are taken as near to those populations and patients as we possibly can.
Okay. Thank you. So, Rekha, I can see your hand go up. I know your question is around services, so I'll bring you in a moment. But Monica, Richard and Daniel, are your questions around what Lucy is leading on around governance? If it is, then I'll take them now. Otherwise, I'll bring you in a bit later on.
No, mine isn't.
Chair, my hand was up to remind you of the other participants, so I'll put it down now. Thank you.
Thank you very much indeed. Thank you. Grateful to you. So I would now like to progress the meeting. And sorry, Richard, did you want to ask a supplementary question around what Lucy is leading on?
Yes, Chair. I was wanting to follow through on the partnership point. Yeah, and I welcome the openness about the discussions on the local authority representation on the ICS board. But there, and I see in some of the external reports, such as King's Fund, referring to cases where there is a much more equal balance between NHS and local authority involvement. But another whole aspect is that I think is either missing or I cannot see is the patient and public involvement and the voluntary sector and carers involvement. Could you explain where that is in the governance and assurance structures? So that
Thank you,
those
Richard.
voices, yeah.
Thank you, Richard. Leslie, please.
Yeah, so thank you. So there, I'm going to send these structures out to you so you can see. So both Health Watch and some of the voluntary groups are on the wider group, Richard. On the comment about more equal representation between in other areas. So we did have this discussion actually with leaders, and this is tricky stuff in some ways, and you'll all have views on it, which is, if we're all sitting on the board and making the decisions, where's the scrutiny? And actually, where are all those discussions, if you like, taken and scrutinised in the way that they are now? There are a variety of views that says, I want to know about the decisions, but actually, if I am part of that decision making, how am I, and are held to account for that decision making? So if I'm a local authority person, how then, how then is that scrutinised elsewhere? And I think that's one discussion. The second bit is that at the moment this is about it's about partnership working, but the accountability for the spending of health money sits with health at the moment. And often, and this is a discussion I've had with local authority leaders and chief execs, we are not actually talking about at the moment about integrating all the budgets, which would be a different situation when, of course, if we were talking about local authority budgets and expenditure and decision making coming through that partnership board, then actually, and hopefully at some stage we'll get to that, that would be a much more of a joined up whole system. But at the moment, although it maybe feels slightly, I don't know, unequal, I hope it doesn't, but if it does, I apologise for it. Actually, in general, we're talking about the expenditure of health monies and money coming down from health.
Thank you. So I'm going to make some progress now, and I know.
Before we do, sorry, Keaton. Before we do, Judith Davey has had her hand up, and I presume wants to contribute to this section. It would be remiss of us not to allow her.
Sorry, I can see Judith's hand on my screen. Thank you very much, Daniel. Judith, please, very quick point from you before I move forward. Judith,
yes,
and very welcome to the meeting.
Yeah, thank you. So, from a Health Watch perspective, as the champion of resident voice and patient voice in relation to health inequalities, I think that we as an institution, and also the residents and patients that we engage with, can absolutely see all the great work that's been done under COVID. But I think that there is a real sense that the health inequalities that we say have been discovered during COVID, actually we all knew that they were there beforehand. So some of the things that we are now saying, and I understand why we're saying those things, and they are important things to do, but things like we need to join up. We now know that joining up is important. We now know that telling a story once is important, is landing in a quite difficult way in relation to the residents and patient populations that we serve, because this isn't new. So I think there's a sense of, there's a bit of a cynicism about saying, oh, we've learnt a bunch of stuff from COVID, because COVID may have made it worse, but it was stuff that we all knew was there beforehand. So what actually is going to be different moving forward? So I just wanted to share that at this point of the agenda. Thank you.
Thank you very much for that, Judith. And Rekha, thank you very much for sitting so patiently. I'm going to bring you in very shortly to talk about the quality of service that Leslie was saying in the presentation. But before I bring you in, Rekha, let me just very quickly ask you, Leslie. So what is going to happen to the single CCG which came into play not so long ago, as the white paper suggests, that it will no longer be a separate body? And I also want to understand very briefly, please, the commissioning aspect as well. And then I'm going to bring Rekha in.
So thank you. And by the way, I agreed with everything Judith says, and out of here I will have a discussion with you, Judith. So I think the CCG, the single CCG, will be assimilated into the ICS as if the bill goes through. As you know, it's second reading today. But that's our assumption at the moment, and we're working to that assumption. Now, the commissioning arrangements in essence change because we're not in competition between NHS organisations. Actually, there is an approach that says we have to decide ourselves in our sector the best way that we can provide these services together for the patient population and the needs that are identified. And therefore, the amount of external commissioning is much reduced. And we will only be doing that where we absolutely need to do it. There is some discussion that we will need to have together with our local authority colleagues about the commissioning and the contracting of services that are both undertaking on our behalf and are undertaken by local authorities into NHS services, but that's still to be developed.
Thank you very much. A quick point from Mohini before I make progress. Mohini, please, and very welcome to the committee.
That's fine. I don't need to say. Leslie made the last point that I was.
Okay. Thank you very much. Thank you very much. Monica, did you want to come in at this stage? Monica?
Thank you. My question is slightly different, but looking at the wider context, all these changes and sound really promising, but the wider context is a significant workforce deficit across both local authorities and health, and looking to get worse actually in health over the next 2 or 3 years with retirement for GPs and so on. So my question is what level of strategic workforce planning is happening that's going to actually ensure these changes can happen on the ground?
Thank you, Monica.
I think Pippa's going to answer that actually, Ketan, if that's all right.
Thanks,
Pippa,
Monica.
welcome.
Thank you. Welcome. Hello, everyone. So you're really right. It has been a concern of ours even pre-COVID, actually. You know, we know that health jobs, particularly in nursing and other AHP jobs, are not becoming favourable careers for people to go into. But luckily, we had lots of work that was in trail before we hit the pandemic. And actually, what the pandemic has done is something opposite. We had double the amount of applicants into nursing and midwifery this year, to the point where universities have not been able to take a number of really good applicants, and actually we can't place them. Now, I think what they all think is we all get clapped outside of a hospital, and if they knew what was happening inside the hospital, that might not have been the case. But for medicine, for nursing, for midwifery, and for the first time mental health nursing, over subscription to mental health nursing, which is just fantastic. And I think the bursary has really helped that. So the bursary is back, and the bursary, the highest amount goes to a learning disability and mental health, which is fantastic. The other thing that we've done, and we're just about to put a bid in actually into the GLA fund for this, but we have developed a Northwest London Academy, and we're really trying to employ people locally to work locally. So what we're doing is employing them from job centres into our entry-level jobs, and then we're training them. So what we've done is we take them as band 2s, and then they go on to a nursing associate and a degree apprenticeship associate after they are paid to do their degree. So within 5 years, they're a qualified, whichever professional route they've entered. And we've just put a bid into the GLA to now fund that academy more sustainable, because I think this is the way forward, actually. I think employing locally is something we've all really got to get behind. And I think what that does is helps with our retention as well, because if people work and live locally, then that whole anchor institution really comes to life. So that's something that really excites us, and we're quite a way down the line within Northwest London. So although we've got some shortages, we're in a pretty good place for most of our clinical roles.
Lovely. That sounds really exciting. Thank you. Thank you very much.
So, Pippa, I forgot to introduce you to, I'm sure colleagues know, but for the sake of completeness, colleagues, you will know Pippa Nightingale is the Chief Nurse for the Integrated Care System, and of course, Chief Nurse at the Chelsea and Westminster Hospital too. Thank you very much, Pippa, for that answer. And perhaps I'll come back and pick up on that reply a bit later on, Pippa, if time allows. But I'm anxious that I've thus far not brought Rekha in, and I do want to now bring Rekha in. Rekha, thank you very much for your patience, and good morning to you.
Good morning. Thank you, Chair. How will the ICS be driving tangible improvements to services, especially the maternity services at Northwick Park Hospital?
Thank you. Leslie, do you want to pick that up for me, please?
Yeah, so I'll take the general, and then I'm going to ask Pippa to talk about Northwick and maternity.
Please.
So I think it's a good question, and I think we will only do that actually by working together. So I think there is something, and in a way you've sort of nuanced it through this, which is the needs are different. There's some needs that are universal, but there are needs that are different in each of our boroughs, and we need to be absolutely clear that we're permeating populations, cohorts of patients in a way that we need to. We need to think about population health, prevention, and then world-class delivery of primary and secondary care. But we will work together, and I don't want to go. There's a lot of detail around this, which I'm happy to do, but I can tell that today's not the time. But we will do that as a single item around the improvement of care that we can deliver.
Thank you.
Thank you.
Shall I touch on maternity?
Yes, please, Pippa.
As you know, maternity is under scrutiny across the country, not for the first time, actually, in a number of years. We do have a service within North West London that is a concern to us, and as you all know, that's Northwick Park. Now, actually, I've done a lot of work. You know, might not know, but I'm a midwife by profession. We've done a lot of work reviewing the services at London North West, actually, and what we all feel as a clinical group is we are committed to improving the maternity services at London North West. As Leslie alluded to at the start, what has happened with this territorial breakdown of organisations is actually we need to think about our pregnant women and families across the whole of our system, and our families in them boroughs deserve a really high quality maternity service, and that's what we're committed to providing. What we can't do is repeat some of the interventions that have happened in the past, because this is an organisation, a service that makes some improvements and then they go backwards, some improvements go backwards. We cannot just do that again. There's no quick fix to this. This is a long-term solution. So we have clinicians from all of our other maternity services that are working together in that unit with the clinicians to really try and unpick this cultural dynamic that is happening with that service and has done for many years. We're also moving some of the clinicians from that service to our other services in North West London just to see how a high quality maternity service does run, and for them to learn and develop in that experience as well in them environments. So this is a long-term fix. We've got a very good understanding of it, and we've got a very good commitment to clinicians across the system to fix it.
Rekha, did you want to come back?
No, I think I'm happy with this. Of course, we have scrutinized Northwick Park maternity before, and it improved, but it's gone down. So I only hope that we can only improve and not go down again and again. It's repeating. History repeats, you know. So,
thank you very much.
Yeah,
thank you very much for your patience in me calling you. Leslie, I want to pick up your general point, and again, a quick reply would be appreciated. But before I pick up that point, let me ask much more general question. And you made a reference to us in your opening remarks, particularly mental health. But I also am keen to know how the ICS is going to bring about the quality improvement in not just one or two service areas, but right across a service delivery provision from one side of the area right to the other side of the area. So let me just ask, what work is being done at the moment to see that winners and losers are going to be mitigated, so that there is I think you said population health, and Judith was talking about inequalities. I just wanted to be able to understand how is that going to be mitigated. So rather than peaks and dips, the line is going to be much more flatter, so that there is a general offer which is going to be driving that agenda.
So thank you. So very quickly, so in essence, for every specialty and for every subspecialty, there is a clinical reference group, which actually isn't just by hospital, but across the whole sector. There is for the acute units, I'll use an example, there is collaboration between all of us, and we're looking actually around our own governance structures. You know that actually we're considering about whether we would go with one chair across all 4 units to try and bring that absolutely equality of provision of pathway for all patients. That's one example. In terms of mental health and community, so our mental health providers, again, are working collaboratively together to ensure that actually the actual pathways for patients that are designed together by all of their clinicians are the same for patients all across North West London, and actually are again, looking at how they consolidate some services. So particularly some of the most, for us, in mental health, and I don't know if Mando is going to talk a little bit about this, but particularly around mental health, about how we consolidate some of the very serious mental health provision across the sector in a way that we just haven't managed to up to now. So it is clinically led. It is about doing it as locally as possible when you can, consolidating very specialist services and working together and bringing the governance arrangements together so we don't have quite so many debates.
Thank you. So, Mando, not just mental health, I'm also keen to find out about children's services, again, right across the 8 Northwest boroughs. How is ICS going to help underpin that piece of work so that whether you have services in Hillingdon or whether you have services in Westminster, the offer is going to look pretty much similar, and we are going to have the best possible outcomes, irrespective of the fact that you're Hillingdon or you're in Westminster.
Karen, thank you.
And for those who don't know Mando is the lead for children's services and also a senior consultant at Imperial College NHS Trust.
Thank you, Karen, and a huge thanks for inviting me. And I guess the first thing to say is that we are looking at 25% of the population, if you're thinking about children, or if you include young people, 30% of the population. And just the fact that I am here and just the fact that the ICS has a children's programme is a really important starting point. And that is, I can assure you, not the norm. ICSs up and down the country do not have that. So I think we're already a step ahead. A lot of the things I'm going to say, or I think in response to that answer, echo what Pippa said for the whole population. For example, we have this very mature data system that means that actually we understand much more what the needs are of our population and indeed our children's population. I think a lot of the time when people focus on health and well-being, they think about the whole population and merge adults and children, and actually being able to disaggregate what we're doing for children and focus on that especially is important. And if we get it right for our children, actually we're getting it right for the future. And I guess one other sort of point that I'm sure you know needs no rehearsing is that actually as individuals, I think we put our children first, don't we? They are so precious to us. But actually as organisations, we need to do the same thing. So the ICS has gathered together for the population of children, so not for a service, but for the whole population of children, the assets that we have in the system. And we have extraordinary assets. We have young people from Healthwatch who will stand up and tell it how it is. And that voice is extremely important resource. We've got, as Leslie said, Imperial College with the most extraordinary international experts in child health. So, and we have fantastic organisations that deliver care, and actually we've started to knit those together. And I think it is about joining up the strengths and resources that we have with the needs of our population. And so just perhaps to be a bit more specific, we're talking about things like information for parents to know what to do if they're worried about their sick child. That we're talking about children living with asthma and being able to live with asthma without risk in a school and be well supported. We're talking about stabilising a critically ill child from wherever they are in the sector and safely transporting them to the intensive care unit at St Mary's. The programme is addressing the depth and breadth of child health in that way.
Thank you very much for that. Lucy?
Thank you. I'd like, if I'm able, just to drill down a little bit into Councillor Seth's question about the distribution of resources and the transparency of that, if I may. We are I'd like to ask about how we can how we as local authorities can know about the distribution of funds about population health needs to make sure that each council is being treated fairly. I just want to give a small example, allocations of the Ageing Well Transformation Fund. Brent was able to receive an allocation of 1.8 million, Harrow 1.4 million, and Hammersmith and Fulham 800,000. We haven't had a sense I think this question is valid for all because it's about transparency of working and governance. We haven't had a scientific explanation of the allocation of this funding. We've been told by a health representative that it was made on pragmatic grounds. And I'd just like more clarity on that. If not here, but yeah, I'd like to know.
Thank you.
How that worked out.
Now, Leslie, are you able to pick that up for me, please?
I was expecting Mando to answer that question, actually.
Mando?
No, I'm joking. That was my joke. Sorry. So in terms of the Ageing Well, that was a national PHE allocation, so that didn't come from by the ICS. There are, as you know, formula at the moment for allocations. Actually, those allocations will be unified and come through the ICS, which will allow us to make some adjustments in a way that I think not all of us will like. So I mean, I've had this discussion with both your leaders and your chief execs before. If and when in the treatment of inequalities, it means, for example, health money that at the moment we spend, I could pick anywhere, but let's just say Westminster, and we decided that actually we needed to move a bit of money to Brent. Actually, Brent would be happy and Westminster will be unhappy. And so there is something for all of us that says, and why we need to go back to principles of what are the minimum things we have to provide for everybody. And actually, then how do we build on those improvements? Because we will not address inequalities if we don't move resources around, be that money or indeed staff or kit or whatever. Now, we haven't got into the, at the moment, we have left money where the money is allocated. Bear in mind that Northwest London has a structural deficit of 400 million. So that's a 400 million every year we spend that we don't have. And therefore we are spending somebody else's money. So the first task is to try and actually make sure we're as productive as we possibly can, to put a plan together over a number of years to recover that position. But actually, I guess I'm laying down a slight gauntlet here that says if we do intend to address inequalities, it may mean that there will be some discussions between us all about really, are we committed to doing that?
Thank you. Thank you. Thank you very much. Okay, I just want to go back to the long point that I was leading to just a moment ago. And I've been saying not to make long points, and I in fact made a very long point. And let me just go back to that point. And I'm interested in finding out, Mohini, if I may, as a supplementary to that point, how is the primary care, as the primary care lead for the ICS, are going to be driving the quality of improvement? And I think it'd be really useful to know that, particularly around prevention, because, of course, more we try to deal with the preventive area, the less the pressure will be on the secondary and the other areas.
Do you want me to come in on that now?
Yes, please, Mohini.
Okay, so there are a couple of questions there. So if you're talking about quality improvement and consistency of offer for primary care, absolutely, that has to be, we have to agree. So people might know, and Councillor Crawford will know this, that certainly in Ealing, we commissioned the Ealing Standard, which says irrespective of who your GP is and where you live, this is the expectation we would have from your GP practice, which has a quality markers on the services. It also actually has a number of appointments that should be offered per 1,000 and breaks it down into GP, nurse-led, face-to-face and telephone. Of course, a lot of that got paused during the pandemic. And so I would expect that that is where we need to go, is to say what is the right offer for the residents, and then understand where the gaps are, and then align your incentives and the transformational resource to make that happen. And it is possible, because when we look at diabetes across the 5 CCGs over the last 8 years, and if you look at where Hounslow was 5 years ago and look where Hounslow is today, there is a massive, massive improvement in diabetes care and picking up people with who have not yet developed diabetes, so that actually you put the prevention in place to stop them developing diabetes. So the evidence is there that if we are clear about what we want to do and we align our incentives, that actually working in that way can make a difference. So I think that is what we need to do. Primary care at the moment is dealing with 3 things. The backlog on our management of long-term conditions, which is clearly there, and we are going to be discussing this in our primary care SOM and giving some of the data to Leslie tomorrow. There is secondly about dealing with everything that comes in on a normal basis to primary care, children who are unwell, trips and falls, and people with just the normal business of primary care, which a lot of people have been sitting on, and they are now coming forth. And thirdly, about dealing with our workforce, because we combine the same issues. We have a retired workforce. We're running 20-25% less on capacity because of isolation. So whichever way we go, the next 6 months getting through winter is going to be a challenge. And the only way we're going to get through this is we collectively work together. We are all patients as well.
Thank you.
Thank you.
So I think you finished very nicely, which leads us to our next item, Nhs Recovery. And I think backlog, which you have referenced a number of times, will, I'm sure, feature in that next paper. But before we come to the next paper, is there any other final point any colleague wants to raise before I bring this to end? And I'm also keen to know if any colleagues would like further information or would like to make any potential recommendations going forward. Lucy, please. Lucy, and then Rekha, and then Richard.
Sorry, it's I just pressed the wrong button. I just point of clarity. The Aging Well Transformation Fund. What is the PHE? PSE? And you said it was a PS.
I think it was PHE, which is Public Health England.
Okay, right, great. Just to clarify.
Apologies. I shouldn't have.
Thank you.
I should have guessed what it was.
Thank you.
Thanks.
Rekha, please. Your microphone, please, Rekha.
I'm sorry, Chair. I've got a question about Mount Vernon. Is it time to ask now, or you want me to wait till next?
So maybe you can just park that for the time being, and you can ask that certainly when we're talking about recovery, and we'll try and slot that in. I am keen to make progress because we have passed our hour already. Time just moves on very quickly, I'm afraid. Richard, please.
Thank you. Thank you. In terms of information, you've already said that you're going to send us a copy of the development plan that's been submitted to NHS England. I'm also conscious that the ICS is moving very quickly in terms of the development, and that you're briefing council leaders monthly. Perhaps that is also a briefing that you could share with this committee, so that we are following on the journey, understanding as the journey the ICS is going on. Thank you.
Thank you. Any other items of information or recommendations? Can I just add mine? Then perhaps I think, as we were saying, this is very early in stages, and I'm sure there's going to be a lot of work which is going to be progress in weeks and months ahead. And I think it perhaps would be useful for us to have another review potentially in 6 months' time. So perhaps we could agree to that as well. Okay, anything else? Michael, can you just remind us of the stuff that we have thus far agreed, please?
Yes, Chair. So I have an information request for a copy of the development plan, which was mentioned earlier in the discussion. and also the monthly briefing, which is provided to council leaders to share with the committee. A review in 6 months' time.
Thank you.
Also, I just prompt members in case they were interested to know about the timetable for the ICS restructuring, because I know that was mentioned by members earlier.
Thank you. So again, if you can have that as well, and if no, that can be noted down as well. Judith, did I see your hand go up? Sorry. Okay, great. So Leslie.
So I didn't put my hand up, but I put a comment in the text, which I'd be grateful if colleagues could read.
Okay. Thank you very much. So committee, are we happy with those requests for information? Can that be agreed? Leslie, we will be writing to you for that as a reminder, and if that could be action from your end, it would be greatly appreciated. And so thank you to all the contributions for this particular paper. Grateful to you all. So we will now move forward to the next item. And the next item is the Nhs Recovery and COVID-19 vaccination. Can I suggest that we take the Nhs Recovery bit first, and then we take questions, and then we come to COVID-19 vaccination, and we take questions on that to keep it nice and clear, if that's okay. So Leslie, are you going to be leading on this as well? So if we can hear from you about the Nhs Recovery first, then please.
So I think in general, I've talked quite a lot about the recovery. The only bit that maybe is about primary care recovery. Actually, I didn't probably say enough about that, which is, and Mohini's talked a lot about the amount of pressure that they've seen. We are nearly at the 60% face-to-face consultations now, and working towards that. But as I said earlier, there has been diversion of primary care resource to vaccination. Other than that, actually, our recovery program is monitored by nationally, literally weekly, actually the Elective recovery program, and we're at about 75 to 80%. For some hospitals, we're much higher than that. For some modalities, we're way ahead of the ask. And actually, we do report this in public. So I will ask actually for the next meeting to give you some idea of exactly where we are by trust in terms of the recovery program. I don't think there's any problem with giving you that. So, but that changes every week, frankly. But we're well on our way.
Thank you very much. Did anybody else want to add anything to what we've just heard from Leslie? Mohini, did you want to add anything?
No, the chat that Judith has put through, do you want me to respond to that at all?
So I haven't looked at the chat yet, but
yeah.
Does it form part of this conversation?
It talks about prevention in primary care.
Okay, please do.
Yeah, so yeah, absolutely, quite rightly, because of the pandemic, we've been focusing on COVID. So I think as we move forward into prevention, we're going to have to work differently. What we are talking about also is seeing how public health can work within PCNs to understand what are the prevention needs that are happening locally. And in the new way of working, as we are going forward, as you've outlined, with the deficit, with the workforce challenge, I think we're going to all have to work differently, both as the public and as primary care providers, because I think NHS was going to have its hands really more than full with dealing with the backlog over the next 6 to 12 months.
Thank you very much for that, Mohini. Grateful to you. Richard, if I can bring you in at this stage, we have talked about in the last paper, and you have just finished making reference to backlog, and I know Richard has questions around backlog, so it'd be good to bring you in at this stage, Richard. Thank you.
Yes, yeah, thank you. Very keen to get some transparency over the backlog and how that varies by geography, by demographics, and sort of by speciality. I see this very positive statements in the report that everything is being prioritised by clinical need, but I would like to I'd like to see the data that backs that up. An Asian patient in Nhs is as likely to get services as a white patient in Kensington. So some of this geographic and demographic data about the degree of the backlog, waiting times, or whatever is being monitored there, so that we can actually demonstrate to residents that there is equity across the very big geography that we're talking about.
And I think we touched on this in the last paper as well, and I think Judith was highlighting that aspect as well. So Leslie, please.
Yeah, so we do report this stuff actually, but not by individual patient. But just to and I will send you the reports that we publish. As I say, they'll change every week. But just to reassure you, these are clinical decisions. First of all, about clinical priorities. So our cancers and our P1 and P2, which are the most sickest patients, are seen first. Then we do them in date order. And date order actually is our biggest tool in terms of addressing inequality, because if we do it in date order, actually in a way that's blind, that actually just says however long you've been waiting, you will be seen first. But I will send you all of that, the data that we've got, Richard.
Thank you. Richard, please.
Quick supplementary on that. Date order could be an issue if people have different access to the diagnosis or the start of that process.
Yeah, I can pick up on that, Richard. So what we've had to put in is a new governance process, because we know we'll be working in this way. Let's not kid ourselves for 1 or 2 years to really catch up with this. So what we've put is a clinical governance process in place where every single patient on our waiting list has a clinical harm review. And in that harm review, there's a review of the physical harm, but also of the psychological. Some of our referrals, our longest waiters, are actually for things like pain services. So there will be no risk to the actual physical harm, but psychological harm is high. And also the social economic background as well. So that's all part of the harm review that's undertaken for every single patient on our waiting list at the moment. And that's what we're doing to ensure that we've got the right decision making, clinically driven, to make sure the right patients are being operated on in the right order. Just one thing, other thing for me. So you're absolutely right. So actually, this is only a first step. So the way that we deal with the waiting list actually probably does help us in terms of knocking out the inequality of access and outcomes on the waiting list. The issue actually that you're talking about is actually do we offer both preventive and first appointment, and indeed recognising diseases in some of our most deprived vulnerable populations. That is a big piece of work that we need to do together. Actually, that does speak to population health. It does speak to local authorities and health working together in a much more joined up way of identifying these people. I mean, we could pick up, I won't do it in here, we could pick up some specialties where that is absolutely the case.
And this piece of work is happening right across the 8 Northwest boroughs?
Yes, in this exactly the same way. And there's one meeting that then it pulls it all together. So we see the whole patient list as one. And that's the first time we've ever done that in Northwest London. It's the first time we've ever seen a priority list that's clinically driven for the whole of Northwest London.
And of course, it goes without saying that those hard-to-reach communities are very much part of this work as well.
Absolutely, yeah. And bear in mind, many of our staff come from these communities, so it is an important message to our staff as well, actually. So we need to just ensure that all of that is done in a way that's both sensitive to populations and to the staff, but actually really gets to how the things that all of us are talking about. But we do need to be sensitive about it, but we need to be pretty determined.
Thank you. Richard, did you want to come back?
No, I think that's covered it.
Thank you very much.
Very helpful.
Thank you very much for that. I'm grateful to you. Monica, please.
Thank you. I think Leslie kind of answered part of my question, because I was going to ask how far off the 60% target face-to-face consultations were, but you mentioned that you're nearly there. So I guess sort of following on from that is how geographically that looks, and also what's that meant for referral onto secondary services, as well as prevention, and the impact for that on inequalities across the area.
And perhaps if I can just slightly broaden it, I think it'd be useful to know, it would be helpful for this committee to appreciate what are the actual targets as far as electives and outpatients procedures are concerned. And perhaps Mendo, working in that area, might want to perhaps interject as well. Leslie first.
So it is different across the boroughs. I don't know, Mahini or Pippa might be able to give you the actual, I don't know if we've got it here, but I might be able to answer that, and then we can talk a bit about outpatients.
Yeah, so do you want me to come in? So I don't have the exact data on where it is by borough, but, you know, practices are moving. I can tell you from my own practice, it's a changing field. Every day we are seeing more face-to-face than we were doing previously. There is no cap on making referrals, but every GP has been advised that you follow the Northwest London guidelines, which have been clinically developed by each and every clinical reference group, and we all abide by those guidelines. And the idea for that, and the principle behind that, is actually that is the way we're going to drive out variation, because referring less is just as bad as referring more, and both of these could be bad. So both of those need to be addressed. There is no cap, but every GP is advised to use the referral guidelines, seek advice and guidance, and make the appropriate referral, because that allows us to get the right person at the right time sooner rather than later.
Thank you very much for that, Mohini. Grateful to you. Mando, please.
For the children, I think one of the things we've tried to make as strong as possible is the relationship between families and their family doctor, and actually helping GPs to be very well supported in their child health activities. So parents don't hesitate to see their GP, do get good advice when they see them, and the GPs all now have both telephone and email support from all of the hospitals in the sector, so that they can literally pick up the phone and speak to a consultant anytime, quickly and easily. And that is a very strong message for families who feel that they can see their trusted GP and get advice for their child, and their trusted GP has access to specialist care and child health expertise very readily. And right now, in the coming weeks, I think we do have a looming problem with more and more children getting infections and huge pressure on the healthcare system. But what we want to do is move the pressure upstream so that families feel confident to self-manage their children's illness and know that they will get help when they need it.
Thank you very much. Monica, please.
I suppose as a follow-up question, my question about referrals onto secondary services was really not that there's a cap so much, but where there's a potential link between potentially, not necessarily, between lack of face-to-face contact and getting referred on as appropriate. So telephone diagnoses and those kind of things, have they worked sufficiently well to replace face-to-face contacts in getting people the secondary care that they need?
So
Thank you, Monica.
Can I comment on that? So absolutely. The big game changer was video consultations. And right through the pandemic, I have made 2-week referrals, made referrals through the system through video. There are certain things where you absolutely need to see a person face to face, and you can look at children under 5 and you can look at people with certain conditions. But I do not think that should be a limitation as we move forward. But I think what we do need to recognize is that the balance of face-to-face, virtual and telephone has changed and will continue to change, because actually the way we were able to deliver services through the pandemic in a safe way was through telephone, video, and doing it virtually. But that does not distract from either doing home visits or seeing people face-to-face.
Okay, so one last question, if I may, is the potential, I mean, this is a genuine question, the potential inequalities of access as a result of those different forms of consultations?
Yeah, so absolutely. We know that there'll be a certain group of people for whom this is not the right answer, but we have to flip it the other way. For giving this to the people who can, we actually have time for people who can't. So we have to apply that logic. For a large group of people, this works extremely well. We had some of our patients who had moved out of London. We were still able to offer services to them so that actually we can focus on those people who can't, and they will be your elderly, your vulnerable, your learning disabilities, and so on.
Okay, thank you. Thank you.
Thank you very much. So we talked about ICS in the first hour. I want to go back to ICS and pick up this issue about backlog, Leslie, if I may. And I just wanted to find out how the capacity is being created and crystallized right across the ICS area in terms of mitigating the backlog that we have all been talking about just now, please.
So we're using, in a way, everything that we can possibly do, right from outpatients at the moment, actually. My last thinking about when I looked at outpatients earlier in the week was actually, I think we're doing over 100% of the numbers of outpatients that we're seeing pre-COVID, to try and actually both stabilise and eat into the backlog. We are doing the things that I've talked about in terms of consolidating some specialties together. So clinicians from each of our hospitals are doing work on the high volume, so very high numbers, but less complex cases. And we're doing those in what we call green zones, so areas where actually they're protected from any form of COVID, so we can get through numbers very quickly. And we've been doing a work on consolidating some of the hyper specialist stuff again, so that we can consolidate resource. On top of that, we are asking staff to do clinics and operating lists into evenings and weekends. We have used some of the independent sector capacity that are available to us in Northwest London, and indeed we're looking at bringing some private and independent capacity into our hospitals to support some of the work that we're doing by increasing the capacity by using bank agency and extra shifts. All of those things are going on at the moment across all bits of the service.
Thank you. Thank you for that. So grateful to hear that. But as you are trying to mitigate the backlog, and we are all grateful to you for doing that, you also referenced in your previous reply the potential third wave, which may be just around the corner. So I just wonder, obviously, on one hand, the staff are incredibly tired following the pandemic. You have a lot of staffing concerns. I am sure you are mitigating the backlog by maximizing the capacity, and now you've got the potential third wave. So I just want to understand that this is not going to mean that the backlog is going to remain backlog, whilst your focus is quite rightly on the third potential wave.
You know what, I'll answer that. So so the planning we've done around phase 3, we have to remember we're in a very different position. Phase 1, we had absolutely no idea what was coming our way and how to manage it. We are now in a very different position. We've had time to plan, we've had time to think, we've actually, quite frankly, had time to prepare and train our staff. But what we've got is very detailed plans about how we continue doing our elective work and manage wave 3. And we've got very detailed plans around that, and they look very optimistic. Looking at the modelling that we see every single week of our COVID cases, we're actually in a pretty good place right now. I know we're talking about being in wave 3. What wave 3 looks like is the transmission is between the sort of 16 to 20-year-old group. It's very high in them age groups. It is not resorting into many admissions. There are some admissions, and they've gone up very slightly, but very slightly. And even of the admissions, very few of them are needing ITU care. They are admissions for other reasons. So I think wave 3 will look very different. We're very optimistic about that, and that's actually because we've vaccinated, we've prepared a community. We have all lived differently as a community, and that's starting to sort of pay off for us.
Thank you. Colleagues, are there any other questions? Monica, please.
Yes, thank you. Something I just thought of really, which hasn't been talked about today, but has been talked about nationally in the national press quite a bit, is which is long COVID. And obviously the surge that we're seeing in the Delta variant affecting younger people is possibly not going to have, the impact on hospital admissions, but there is a concern about long COVID, and which is already an issue. So my question is really about what preparations are being made for long COVID.
Thank you.
Is long.
Thank you, Monica, for that. Mohini, please.
Do you want me to answer that, Leslie?
Yeah.
Okay, so absolutely. So long COVID, there's been some national drivers around that. So we've got 3. So if you look at the 3 outlets, so in the acutes, we've got 3 PCACs, which is our post-COVID assessment clinics. There's one at Chelsea, one at Imperial, one at London Northwest. We have also got in each borough an integrated long COVID response, which is an integrated response both from community and our mental health services. And this is there in each borough. And we're starting now to finesse some of the services that are there. And then going back a step, in primary care, nationally, there has been a enhanced service also, which looks at GPs identifying people with long COVID. And then the pathway for them is one of 3. One is self-management, because the fact is a lot of people with long COVID are going to get better. And the difference between long COVID lasts 12 weeks and then after 12 weeks, it's the post-COVID. So 85% of people will actually get better, and structured self-support with, and we're working through some of the apps and digital support for these people. That's being worked through right now. What we don't know where the gap is in the first wave. As you know, we weren't testing people in the community. We weren't testing people in the hospital. So though we know all those people who were admitted to acute, we don't know those people who possibly had moderate COVID but were in the community. And it's about identifying those people who might be presenting with other illnesses and then referring them into the system. What I think we are currently seeing is not that much the activity that's being modelled. Certainly for the acutes, we're getting people in, but in the community mental health, we're not getting in people that we thought we would. So we're currently doing a piece of work to understand what are the barriers, if there are any, to those. But this is very much a priority, both at an ICS and at a London level.
Thank you very much for that very helpful reply, Mohini. Grateful to you. Colleagues, are there any questions before I wrap this first part of the second item? Right. Michael, can you just remind us of the points that we have captured thus far by way of information?
Yes. Well, on the key points noted on NHS Recovery have been about the backlog and how that varies by geography and demographics, and the evidence and data that backs up the qualities dimensions on that, and how services are being targeted. Exactly what the targets are has been brought up in that query about trying to define what the targets are, and I would say performance against those targets. And the mitigation measures for the potential 3rd wave of COVID-19, that's been discussed, and how this might affect recovery, and the specifics of what is being done to mitigate a potential 3rd wave.
Thank you very much. Colleagues, is there anything else that you require assistance on this paper before I make progress? Thank you very much. Thank you very much for your contribution on the first part of the second paper. So we now come to the second part of the second paper, COVID-19 vaccination. And I know, having been to a number of sites, the sterling work that is being done right across the Northwest London. So heartfelt thanks to the team that you're leading, Pippa. Thank you very much. So Leslie, is it you or is it Pippa who's going to be leading on this paper?
Well, it depends. If there's glory, I'll have it. If there's going to be commentary, I'll leave it to Pippa, shall I?
That'll be mine then.
So thank you. I mean, I'd say a huge thanks to all of you, because I know I've seen many of you in our vaccination centres supporting the public, supporting our staff, and it's been greatly welcome. So thank you. I mean, what I'd say about the vaccination programme, so we're over 6 months in now. We've got 2 more weeks left of this sprint, or in fact, we're in the second week. We've got 1 more week after this. To finish phase 2. We have administered in Northwest London 2.54 million vaccines, which is absolutely phenomenal. Actually, it's the highest number of vaccines that's been given in any region in the country, which is fantastic. Now, you know, that's all great as a high number. We've still got lots of challenges. So the most challenging thing we're facing at the moment, it's funny how this programme has gone from different challenges that seem to change week by week. We've had the challenge of having people and not vaccine. We've now got the flip of that, where we've got absolutely lots of vaccine and we don't have the people coming forward. So as you know, 2 weeks ago, we opened up to the over 18-year-olds. We sort of always knew this would be a tricky age group, really, and we did a lot of work of insights trying to predict how they would behave. They have behaved exactly as we expected. They really do think they are resilient. They don't need the vaccine. They're not going to be admitted to intensive care. There's sort of some of the things we're hearing back from our youth groups. So our communication around this has been very much, this time you're having the vaccine to support your family, to support your community. It's not particularly for them, and that's how they see this. We've done all sorts of communication, but our activity has plummeted this week. It really has. We've got all of our vaccination centres only really operating to about 30% of their capacity, because that's the people that are turning up. So we've got staff there, we've got vaccines there, but we are really struggling. That's the picture across London. It's also a picture across the country. So the other thing that is challenging is the second dose. So the single thing people want is that second dose so they can then travel. And the interval, as you all know at the moment from the JCVI group, which are the group that advise nationally on vaccine safety, they have said it's 8 weeks between the first and the second vaccine. That's also causing a challenge for our clinicians. They are having to turn away so many people that are trying to get their second vaccine early, and they're being quite abusive, they're being quite aggressive. It's becoming challenging for staff in the vaccination centres. That aside, we did still administer 64,000 vaccines last week. We're on trajectory to deliver 72,000 this week. We've got big events happening this weekend. We tend to find that the younger population, although they could walk into any vaccination centre right now, they like to come to more of a festival event type thing. So we're doing one at Chelsea Football Club that is supported by the football players. We're doing one in the W12 conference centres in Hammersmith Hospital. We sort of thought that hospital is really known to its local community. It's trusted. That might help people come forward. And we're doing one in Harris School, which is another large one as well. In Westminster, and then we've got lots of small spoke vaccination centres in all of our boroughs this Saturday and Sunday, in that sort of last hope that will bring people forward. We have really played with comms, so we have said this is your last chance to come forward. Now that's really not the case. They can come forward whenever they like, but we want to try and put that urgency. I think this is the population that need to really think. The ones that are sitting on the fence thinking they're invincible, they need to know this might be their last chance to come forward. And we have done a lot of promotion about protect your grandparents, protect your parents, protect your community. It's that sort of wording that we're now playing with. The rest, all I would say for the rest of it, so we are hoping to have administered 2.6 million vaccines at the end of next week, which will complete our programme of phase 2. There is an evergreen offer, so the vaccination centres will still be offering to anybody for their first and second vaccine all the way out through August and beginning of September. And then what we do is move into phase 3. So phase 3 is the booster campaign, and we're doing lots of planning around that now. So we will be offering boosters to anybody that's entitled to a flu vaccine. So that's the over 50-year-olds and anyone with medical conditions. So we will start that programme in the 2nd of September, and we're doing a lot of planning of what that will look like. It runs alongside the flu programme. So we do run a very successful flu programme that primary care lead for us in Northwest London. So it will be running alongside that with our community pharmacists, and we're just looking at sort of support we can provide as a system centrally to be able to deliver that as well. So I think in a nutshell, I'll keep it short and I'm happy to take any questions, but that's very much where we are with the vaccination programme.
Thank you very much for that. People are grateful to you. Richard, please. And then Lucy.
Yeah, thank you. Very good to hear that about excellent work that's happening. Once again, I'm going to ask for more data in terms of vaccination rates by borough, by cohort. I do work in another part of London where we see almost on a daily basis a matrix with that information, which shows over 90% of some cohorts vaccinated in an outer borough, and perhaps only a 60-odd% for the same cohort in some inner London boroughs. So I'm conscious that there is differences, and that some of those differences are also socioeconomic. I know that there was a big issue with vaccine hesitancy, particularly with the Black communities, and a lot of investment has gone into reassurance, and that vaccine hesitancy across London for the Black communities has reduced. I'd be keen to see confirmation that that has applied also in our communities in northwest London. And there's been lots of good practice. I know that within Hounslow, Thursdays at the Gurdwara and Fridays at the mosque have been very effective. So wanting just more reassurance that this best practice is happening, and we're getting equity across the whole northwest London patch.
Thank you very much for that, Richard. Pippa, please.
Thank you. So we do publish the vaccine pack every week that goes to all local authority leaders. So happy to share with this group as well, because it gives you that exact breakdown by borough, by age groups, by the definitions that are set by JCVI. So you're welcome to have that every week. What I would say is, yes, some of the success that we've learned from this is actually how some of our community and religious groups have been the most successful at accessing some of their populations that we struggle to access. So that's been a real learning for us. And I think what I take away from that is what we've learned from that we need to replicate to other vaccine programs, not just COVID. You know, we have a huge problem in some communities with childhood immunisations as well. Well, actually, what we've learned is if they come to their religious groups to be vaccinated and healthcare people are there doing it, and that improves uptake, we should be doing that for other health promotion programmes that we run as well. So they've been really helpful. They've not been our biggest numbers, but you know, there's an issue with here numbers and then our important groups that are struggling to come forward. So some of the other successes we've had is taking the vaccine bus into really small communities that have had low uptake. Great, we may only vaccinate 20 or 30 people with that bus that day, but that's 20 or 30 people that otherwise wouldn't have come forward and had a vaccine. So we've had to go with all different approaches across all of northwest London with the vaccine buses, the community halls, the religious groups. We've had literally pop-up tents happening on street corners in some of our communities that have literally attracted some people that live in that community. We've gone for all different approaches, and I wouldn't say one size fits all, and I wouldn't say one's better than the other. It is a case of you need to do all, and we need to keep learning from that.
Thank you very much, Richard.
Thank you. That was all.
Thank you very much, Lucy, please.
Hi, just to follow up from Richard's points, they're highlighting the disparity between the outer London and inner London boroughs. It often happens. In Hammersmith and Fulham, we have historic rates of low childhood immunisations, and we're having a low vaccine take up as well. I just want to understand more about the variations. I know you've talked a bit about it sort of in detail, with highlighting the vaccine buses and that sort of approach, but I'm looking for a bit more of an overview, a sort of a structural overview about the variations in approach to vaccine engagement, some of which relates to local case numbers, but I'd like more information about that, how this is being coordinated across northwest London. Some boroughs have very rightly received surge report given the circumstances, but I'd like to just understand more about how the decisions are made.
Thank you. So Pippa, please.
Thanks. So there's lots of different metrics we use to decide mainly where we distribute the vaccine to, actually. So what we've done is looked at each borough's uptake, and that has driven the decision of where we deliver the vaccine. So for the last 3 weeks, the inner boroughs have had almost double the amount of vaccine to the outer boroughs, and that's to try and do that catch up. We've also had to respond to things like outbreaks. So we had to respond to Hounslow when it went into super surge, and we had to move a lot of vaccine. Now, that actually didn't come from the rest of northwest London. It came from outer London into Hounslow. And what we've got is a detailed review of our MSOAs. Now, please don't someone ask me what they stand for, but it's our deprived, really small local populations where we can see the uptake is low. So we've had to do micro level allocation of vaccine and different approaches into them. So we've used different data and different data sets to decide where we distribute the vaccine to and where we actually put the smaller clinics or the larger clinics.
Thank you.
Sorry, can I just clarify that? The question I probably wasn't clear. I'm not talking about the distribution of vaccines. I'm talking about the funds allocated for vaccine engagement on exploring why and how, and that sort of strategic engagement with the community that follows vaccine hesitancy, because it's a really complex issue. It's very difficult to understand, and it needs a lot of resource.
Sure does. Yeah, we were allocated.
So I'll take Pippa and then I'll bring Rory in. Pippa?
We were allocated funds to this, and the conversation we had with local authority chief execs when they discussed with them is that was distributed equally across the 8 boroughs. So that was all distributed many weeks ago now to the local authority boroughs for them to support with the promotion of vaccine. They've all used that in different ways. I have to say, what I've learned from this is local authorities understand their populations far better than health. They know how to access into the smaller communities. They know how to use their community groups to support this. They've got good networks into their communities, and they've used that funds to try and strengthen that.
Thank you. Rory, did you want to come in?
Yeah, just on that point, really. So we do have a weekly meeting with the local authority comms teams. This is where I think you asked a question about coordinating the engagement, what we do. And we take advice from those comms teams on their communities, and we work very closely with them. The local authorities have all been very supportive around this. And then we do different things in different areas, as Pippa said. And we look at, different local authorities have produced films. Some have gone, and some of our staff and local authority staff are out door knocking. There's on-street engagement. There's a whole range of activities, but it's coordinated via this meeting we have every week with the councils.
Thank you. Thank you. So I'll take Monica. Lucy, did you want to have any other point to bring out? Otherwise, I'll take Monica and then Daniel and then Rekha.
I did. Sorry, could I just
yes, go on.
I know there's equal funding for that, but there's been some difference in the amount that different councils have had for vaccine hesitancy workshops and things. I know that Brent's been at the forefront of that, and that's a really valuable piece of work. It can't be done without the funding. So I'm talking about something slightly different, I think.
You are. I know what you're talking about now. So that was a separate national pot of Public Health England funding that each local authority could bid for. Brent did bid for it, and Brent was successful in that bid. That was actually before the local authority funds were distributed locally. So that was a separate bidding pot that didn't come through ICSs. It didn't come through health. It went direct from Public Health England to local authority. And I know Brent was successful with that. It was to pilot mechanisms of communicating with communities to deal with vaccine hesitancy.
Thank you for that, Lucy, and thank you for those replies, Pippa. So Monica, then Daniel, and then Rekha. Monica, please.
It's really a question of capacity, both of the vaccines themselves and of staff. Looking at that, we're now going into first vaccines for younger age group. We're looking at second vaccines for people who have been given their first, and then coming in very quickly to the third vaccine booster for people who are eligible for the flu. So it sounds as if come September, around that time and onwards, there's a huge program, I guess, of vaccination possibly happening. So my question is about capacity to be able to deliver those three kind of sort of forces all at the same time.
Yeah, so the plan is to have completed first and seconds by September, and then we go into phase 3, which is the boosters. Boosters, they are a population that we would have already been vaccinating because it's given alongside flu. You now don't have to wait 21 days between the two vaccines, which is helpful. What I'm also really mindful of, and that's the work we're doing, is we have just recruited and trained lots of unqualified vaccinators that were all recruited through local authority job centres, who are a fantastic workforce, actually, never worked in the NHS before. So I'm looking at how we recruit them into a central source, actually, that we use to support this programme across North West London, and that's what we're looking at to do it.
Okay. Thank you.
Thank you.
Daniel, please.
Chair, my question's already been answered. Thank you.
Thank you. Rekha, please. Rekha? Okay, I can't see.
Sorry, yes, sorry.
Thank you.
What is being done to improve the take-up of vaccination for residents who are traditionally not engaged, as well as the others? Thank you.
Pippa, and perhaps Rory as well.
Rory, do you want to answer that, or do you want me to? Oh, Rory, you're on mute.
Sorry, I was on mute. Yes, so we've had a whole programme of engagement with communities who are either vaccine hesitant or people who we don't always reach successfully. So we had a series of workshops on a Tuesday evening called Vaccine Equity Huddles, which are all about looking at reasons for resistance at the sort of population health and right across different communities, with a number of residents and councillors and people attended that. And that has really informed our approach. So what we tend to do is we target specific communities, sometimes via churches, sometimes via meetings that already exist. And we go in and talk directly to those communities. And quite often we will do that when there's a pop-up coming up in their area and say there's a pop-up tomorrow and that sort of thing. So it's been a whole area of work, and it will inform our future approach to engagement with our wider communities, because I think there's been a lot to learn around that, I think, and we think we have learned from it. But it has certainly been a big focus in the last couple of months.
Thank you very much. Lucy, please.
Hi. Yeah, I just wanted to say to Pippa how much, which I didn't get a chance to do last time, how much, what a good idea it is to work on distributing jobs locally. I'd really applaud that. And also to use the local vaccine volunteers. That's something we've been wanting to champion for a while. So could you, Pippa, I was just wondering if you could send us over your comms on that, so we can make sure that we're distributing it as a local council to make sure everyone knows about it.
More than happy to, and your support with that would be great. We have had some amazing people come forward out of the community to run these vaccination centres for us with great skills that we really need to keep engaged, either with local authority, social care or healthcare. But we've had a great resource come forward.
Yeah, it's a brilliant idea. It just makes sense.
Thank you. Any other points, friends? Okay, just very quick two from me, Pippa, if I may. So just wanted to find out, of course, we are very happy, very proud of the achievement that we have in vaccination right across the Northwest London. But how do we compare to the rest of the country, please?
So to the rest of the country, so London is, I'm saying this without having it open in front of me. So the average, so I think we're at 78% in London. We're at 82% nationally. So that was huge before. It's really come down. And of the London average, we've got 4 of our boroughs above the London average. So, and we've got 3 just behind it. So we're actually really catching up. And what I can see when I look at the national data every day, London for the last 2 weeks has vaccinated more than the rest of the country. Now that probably is just the backlog and the bigger communities and the more mobile communities that we've got that we're catching up on. But London is definitely leading the way at the moment and starting to level peg with the rest of the country, which is reassuring.
And what percent?
And the younger population, actually. So the younger population plays into that.
Thank you. And what percent of phase 1 group have we fully vaccinated, please, Pippa?
So of phase 1 group, we've got 82% that were vaccinated. There's a phase 1A group, which is the care home residents, which we've got 94% vaccinated. And we're just putting in a process now for care homes where we're going to make it mandatory. You don't discharge from a hospital to a care home without doing the first vaccine, because if not, we'll always be playing catch up in the care homes. I'm really conscious that through winter, we really need to protect our care home staff and our residents. So we're still working on them groups.
Thank you. Friends, any requests for any information or any recommendations before I wrap this up, please? And I think Michael might have already captured one or two pieces of information that my committee requires. Lucy?
It's a bit of a micro point, really, but just thinking about the application process for vaccine volunteers, there has been reported that it can be quite cumbersome and slow. Could some information be shared about that and how inclusive how available it is for people with additional needs and disabilities?
Yeah, the process, they're not volunteers, most of these, they're paid. So these are people that were registered with job centres. I said the health don't need to interview, the job centre teams interviewed for us and they put the teams forward, we then trained them. So I think through the job centre process, there's real equity in terms of who can access that. They didn't have to complete the cumbersome NHS form. We've also got the JETS programme that we've learned from this and just launched 2 months ago. So the JETS programme is anyone who's applying for an NHS or social care post in North West London from a job centre has a priority interview regardless. So that we're really starting to make links with our job centres to try and bring forward this local community. As you know, I think our best social prescribers are our staff. They are living in our communities. So if we can get that connection right, actually we'll be running a really impressive health service, I think. So there are, you will hear, and I will be honest about this, you'll hear people saying that they've applied and they haven't been taken. And that's because we had so many people that applied and we gave priority to the people who were coming from job centres. We had people apply from across the country. And what we wanted to do is commit to local people having these jobs.
Thank you very much. Okay, any final point, friends? Okay, thank you very much. Michael, if you just remind us of the items that we would like further information on.
Yes, Chair. Got a request for information on communications on vaccination targeting. Also, there were queries about the funds allocated to vaccination engagement and how they've been allocated to boroughs, and specifically VAT funds for engagement on vaccination hesitancy, although that was partially answered around the National Bids programme, and engagement with residents traditionally not engaged.
Thank you.
And also that, I don't know to what extent that was answered already, but there was an information request on the applications process for vaccine volunteers. All
right. Thank you very much for that. And if those can be noted down for us, please. Thank you very much. So I'm now going to wrap this particular item, and then the next item we have before us is item number 7, which is work plan for our next meeting. In particular, so we'll be looking at Northwest London acute strategy as well as the digital strategy. And the friends here would like to add a further item around mental health strategy. So Leslie and the other colleagues, any comments that you would want to make at this early stage?
No, that's absolutely fine. And we'll make sure that we field the right individuals to talk to those pieces of work.
Thank you very much. Friends, any other comments around those items? Anybody? Thank you very much. So any other business? Not aware of any other business. Michael, Nicola, any other business? Okay, thank you very much. So the next meeting will be hopefully at Kensington and Chelsea. Our friend from Kensington and Chelsea is not with us this morning, but we will be liaising with them offline, and we hope to meet at Kensington Town Hall. And the date set for that is 23rd of September. Until then, thank you very much for joining, and thank you very much for your respective contributions. Until next time, thank you very much.
Thank you.
Bye-bye. Well done, Keaton.
Bye-bye.
Bye, everyone. Thank you.